Okay, we're going to do the same thing with lower extremities now that we just kind of did with the hip and pelvis area. Okay? So we'll talk about toes, foot, calcaneus, ankle, tib, fib, knee, patella, and femur. Okay? And this track's really close to the board stuff. Okay? As I mentioned earlier, this class is more of a critical thinking kind of class. What the board is actually going to ask you some critical thinking kind of questions, but don't expect to get an image of a chest and for them to ask you if it's appropriately positioned, right? We're kind of going next level, and we're asking y'all to think critically about that. Now, what's the advantage for you, right? The advantage is simply this. If you can describe how these images were produced, then you can probably tell me a little bit about how the patient was positioned, right? So there is a way, if we know this stuff really well, to think back to positioning as well, to learn something about positioning while we're doing this kind of work. For your board outlines, right, do I expect you to write down, am I really going to test you on whether or not this toe is appropriately projected here? Probably not. Probably not. But what you should be including on your outline is a description of what positioning looks like for the toe, right? And what anatomy should be demonstrated. Like in this case, distal phalanx, joint spaces, middle phalanx, and metatarsal. So this is it looks like a digital image. We have a digital marker on it. What else can we say about this picture? Let's talk a little bit about this picture and use kind of the same criteria that we were just talking about to describe what we're seeing on this image. What are we centered on? Looks like the MTP joint, right? And how did we establish that? We established it in part by measuring kind of these distances here and just drawing like a little cross on here, right? So in addition to knowing where we're centered, doing that measurement has also told us what's aligned to the image, right? We're more or less aligned to the long bone of this metatarsal, right? And these middle phalanx. What can we talk about in terms of, what else can we say about positioning for this piece of anatomy? Slowly opening your Reese's Pieces. It's like I'm having flashbacks to the movie E.T. All right, so one other thing that we can talk about with this picture is there's really not any superimposition of the anatomy. Sometimes you get the little old ladies that have the toes that look like this, right? How you take their toe x-rays, I don't really know. But that is a criteria that we're looking at to determine whether or not this is an appropriate toe exam. Another thing that we'll be looking at is distortion of that middle phalanx, right? If I see distortion of the middle phalanx, I'm probably going to also have this joint space up here is not going to be overlapped because this joint space up here is probably not going to be open because the patient's toes are curled, right? Sometimes that is the patient's natural toe position, right? But in general, we want to see that toe out there nice and fully extended, right? We see the interphalangeal joint and the middle phalanx metatarsal joint, the MTP joint. There's no soft tissue or bony overlap like we mentioned, and we have more or less like a soft tissue technique here, right? So in terms of the technique, we're probably talking about a pretty low KVP and a pretty low MA, right? Okay. Here, what is this image here? How would we describe this image? Lateral or oblique? It's a weird oblique. But the reason that we know that it is lateral or oblique, in part, just looking at this image and describe what you see, how can we make the determination that this is probably looking at the anatomy and what we see demonstrated on this image. I can see a sesamoid bone. What else? There's some superimposition. What else? Look at the soft tissue. There's more soft tissue here than over here, right? So I know that. In addition to that, typically you would see that kind of hourglass shape up here, but I see more of an hourglass on one side than on the other, right? So I know I'm approaching a lateral or an oblique position. So there's twice as much soft tissue and more phalanges and metatarsal concavity, right? That's how we would describe this, concavity, presented on the side of the digit that's rotated away from the image receptor. Okay? What does that mean? We've rotated the foot away from the image receptor, right? And now we can see that soft tissue width and that concavity. No soft tissue, or we want to minimize soft tissue or bony overlap from the adjacent digits, right? And this image looks more or less like it's been centered on this this bone right here, right? It's no longer centered on the joint. So in all likelihood, it was probably a difficult image to obtain because it looks like this was a child, right? We can see the epiphyseal plates. Well, let's talk about the foot. And this is where we've got that mnemonic. Does anyone remember the Colorado mnemonic? Come to Colorado the next 3 Christmases. Come to Colorado the next 3 Christmases. Good. What is that telling us? Can we see all the bones that mnemonic is talking about? No. But so come to Colorado the next 3 Christmases. The first one we're going to say is the Calcaneus, right? Come to Talus, Colorado, cuboid. What's the N for? Navicular. And then what's the 3? First through third cuneiform. Good. Can't write with this thing. Okay. So this is a difficult image to get and to have it appropriately exposed across the length of the anatomy represented, right? Because typically we're dealing with a fairly low technique, and we have a piece of anatomy that looks like this kind of, right? So we would expect to see things a little bit more bright here and more dark on this end, right? Just because of the way the anatomy is working and the way the remnant beam is, okay? So if you ever talk about inherent or added filtration, like what we were talking about earlier, this is one case where we may add additional compensating filtration, right? And the compensating filter for this piece of anatomy would look, let me see, kind of like this, right? We would want the remnant beam to receive more filtration on, wait, I've got it backwards, don't I? Sorry. It's late in the afternoon, I guess. Like this, right? We would want the remnant beam to receive less filtration right here because the image is bright over here, right? And more filtration on this side because the image is dark over here, right? That would be a compensating filter, a wedge filter, okay? So regardless, the foot should demonstrate uniform density across the phalanges, metatarsals, and tarsal bones, okay? Where have we centered here? Third. I haven't quite drawn it right here, but about mid-shaft, right? Yeah, third metatarsal. Sorry, third metatarsal. We want to be able to see proximal calcaneus, tarsal, neck, metatarsals, phalanges, and some soft tissue. All of that included within the exposure field. Okay? And then an appropriate marker. What image are we looking at here? Oblique. AP oblique. Okay? I think it's AP. So we have, that's a good question though. Dorsal plantar surfaces of the foot, right? For anatomical position, the dorsal surface of the foot is the anterior surface, right? It's one of those places where things get flipped upside down. The plantar surface of the foot, we're going to consider the posterior surface of the foot, okay? So, AP oblique projection, all right? Now we can see a little bit more of the calcaneus. Again, uniform density, we don't have quite as much of that wedge shape here because we've created an angle now that's going to minimize that. So we don't need a compensating filter on this kind of image. Let me see. We want to be able to see that tarsi sinus and the fifth metatarsal tuberosity. Okay, what the heck are we talking about? Sinus tarsi right here, fifth metatarsal tuberosity. That's how we know if we've got an oblique image, right? Let me see if there's anything else. And it's still at the same time, the third metatarsal still at the center of our exposure field, all right? So we've included all the soft tissue. This has an actual standard marker. All the soft tissue were aligned to the axis of the long bones of the foot, and we're centered more or less on that third metatarsal. Okay, lateral foot. Now we can see more or less all those bones that we were talking about earlier. Same kind of requirements of contrast and density. Let's see what else. The talar domes are kind of superimposed here. And we're going to see the distal fibula superimposed with what bone is that? So we have a portion of this bone and then this bone here.
Talus?
Yeah, talus. Good. See if there's anything else. So one measurement of this image here, with the prior two images we could not really adequately evaluate the calcaneus, right? So we want to make sure we've included the entire calcaneus on this image. With the prior two images also, we have the anatomy at a different angle to the image receptor, right? Now we can actually see some of these distal tibia and fibula on the image, right? So typically on this image, we're going to include maybe about 2 centimeters of those bones, right? With the previous images, there really was no reason, like you notice with the AP image, we collimated about to right there, right? There was no reason to bring our collimator out to here because it would have just been a superimposed jumble, right? But with this image, we do need to go ahead and open up our collimator just a little bit more because we can see that the distal shaft of the tibia and fibula. Okay? So let's talk a little bit about the calcaneus. We can do this axial projection, so planodorsal projection, right, and then a lateral projection of it. We want to be able to see that talar calcaneal joint. It's a little tricky to see here, but I'll try to outline it. demonstrated without distortion. So that's going to be one of our big measures here, right? In other words, do we have the central ray angled appropriately to that joint space? Okay? Angled like that. So we're talking about an angle of about 40 degrees, right? If I were to draw this on here and kind of indicate the angle that I'm talking about an angle of about 40 degrees, right? We're not going to be able to see the metatarsals very much on this image. That's really not where our focus is. Our focus is primarily on the calcaneus. And the main thing that we're looking for probably with an image like this is some kind of crazy dislocation or just a straight up fracture, right? Pretty rare to fracture, but I've seen it happen more often than not, especially with motorcycle accidents. Any kind of sudden stopping impact accident can fracture the calcaneus. Yeah, it's a hard, heavy bone. If you have osteoporosis or something that's demineralized the bone, you could potentially just step on it really hard. But for most people, what you're talking about is blunt impact directly to the plantar surface of the foot, the heel.
Is that not the, I don't know the real name for it, but the lover's fracture?
Mm-hmm.
You ever heard of that?
I've not heard it called that.
It's where they say that, you know, the person's significant other would come home and would jump out the window.
Oh, jump out the window. And yeah. I can understand what you're describing, but I've not heard it called that. But it could very well. I mean, it definitely is related to blunt impact at that point. So lateral, medial lateral. So we're projecting from the medial aspect of the foot to the lateral aspect, right? So we kind of have the patient kind of frog-legged or laying on their right side, for instance, or their left side if I'm doing a left one, right? And the central ray is entering on the medial aspect and exiting on the lateral aspect. So that would be the projection, right? We want to see those talar domes. And then the tibia-talar joint space open, right? So I can kind of evaluate that joint space there. Let me see. We kind of want to see a nice little 95-degree angle right here, if possible, just because that's going to allow us to evaluate these joints as clearly as possible, right? And then we more or less have the mid-calcaneus at the center of the exposure field, and we can establish that by doing a crosshair method, right? And I think that's it. At minimum, a calcaneus needs to include this image. In all honesty, the other image is very, very difficult to get, I think, especially if you suspect fracture. But I have done them in the past. Occasionally they're helpful in the OR as well. If they're trying to place like a screw or something in here, they want to make sure it's aligned. They may need angulation there too. All right. Bear in mind, right, that if you're trying to get this image, due to the divergent property of the X-ray, you want to be centered more or less on the anatomy of interest, right? Because if you are not centered appropriately, the anatomy will not be demonstrated. So if I'm looking at this picture and I'm trying to determine, was this a good picture, or do we need to repeat it? Centering is a big factor anytime that we're angling, right? Okay. Ankle. AP ankle, right? We want to see that medial mortise joint open, right? And let me see, the talus. Tibial talar joint space is going to be open, and more or less we're centered directly on what? The joint itself, the ankle joint, right? And typically we're going to have the long bones of the tibia and fibula aligned to the long axis of the image, right? Centered on the joint space. medial mortise joint open, talus joint open, centered on the joint. Oh, one other thing we should mention on that image is we want to make sure, especially on these images, that our markers are appropriately placed on the side on which they mark, right? Like, for instance, I would not want a left marker up here, correct? I want to make sure the left marker is on the appropriate side, okay? That it needs to be on the lateral aspect of the joint, in other words. So, again, on this image, we're going to see the medial mortise and the tibio-talar joint as well as the lateral mortise joint. Sometimes this is called the mortise view, right? So we know that this is an oblique with internal rotation, right? We've given it some internal rotation in order to separate the fibula out from the talus and demonstrate this joint space without superimposition. That is the major way that we know whether or not this is an appropriate image. Okay? That's the number one thing that we're looking at. We want to see a technique that allows for some soft tissue visualization. We want to be centered on that joint, and it is especially critical to be centered on this joint because, again, like what I was saying earlier about central ray divergence, if I'm not centered on that joint, central ray divergence could actually artificially close the joint. It's a very small joint, right? Y'all understand what I'm talking about? If say the ankle joint's way up here and I'm centered down here, I'm going to artificially close the joint space because of central ray divergence. I know there's a lot of x-ray techs, or maybe hopefully not a lot. There's a few bad apples out there, right, who like to go and like center wherever and then crop appropriately. That's not doing jack in terms of image analysis. You can look at the picture and very quickly see they were not centered on the joint, they were centered on the knee and then they just cropped it. Okay, lateral ankle. Looks a lot like that lateral calcaneus, and you know we do these quite a bit in surgery. Mainly what we're looking at here is that long axis of the leg. We want to see how the tibia and fibula relate to the joint space itself. If there is a fracture or some kind of trauma to the ankle, we might see dislocations of those bones, right? They may have somehow ruptured the joint capsule. And we want that tibio-talar joint space more or less at the center of the exposure field. Right about here. It's a little bit high. So they probably could have brought the exposure up some. All right. Let's look real quickly at this. What image are we looking at here? AP or it's a lateral. I can see more or less the knee in profile here. It's helpful to see it because the bones do kind of the fibula does kind of bow out posteriorly a little bit, so it's going to be difficult to see them both superimposed, which is nice. We have the joint space open on either side, and yet they appear to be slightly, and that's going to be somewhat patient dependent too. Again, we want image density uniform across the length of the lower leg. The tibia is only going to demonstrate minimal superimposition at both so we'll see it at the distal ends and the proximal end. We want to see the joint, the knee joint, and the tibio-talar joint, right? So what we're looking at is just the tibia fibula from joint to joint, okay? In all honesty, I would not expect a board question on that because it's just like a little bit too easy. Okay, but let's talk about the knee. It's actually a really difficult thing to image. So what are some of the things that y'all are learning in the clinical site to help you center on the knee joint appropriately? What kind of tricks are you seeing? Have they shown you any tricks?
Just to feel for the indentation.
Feel for the indentation and center
Actually feel it.
center more or less on that indentation. It's always weird to me because the knee joint is actually a little bit below the kneecap, right? So we can't really go off the kneecap. It hinges below the kneecap, beneath the patella. What other things have y'all seen? Have y'all seen any little tricks for lateral knees? Anything? What helps us get a good lateral knee?
A lot of times like at Campbell, I know they want you to keep that 3 to 5 angle on the lateral.
Yeah, that angle does help.
Open up that space.
And bring the leg across and kind of make sure their hips are kind of more perpendicular.
Bring the other leg up and over. Is that what you're saying? Yeah, that is that's helpful. And then maybe even prop up their foot. Has anybody been doing that? Propping up the foot with a wedge sponge?
Another thing, were telling me at Campbell's that if you
Because you
can
can
see
just
the
feel
feel
for
of
them,
the
make
foot
sure
up
they're
a little bit, you're most likely to get a good lateral
Yeah.
in general people.
Yeah, no, it is a little bit patient dependent. I think honestly, a lateral knee is just about the hardest. It's about one of the hardest things that we do and do well. When you get a good lateral knee, you should feel like accomplished. You know, it's a deceptively difficult joint to image. All right, we want to see the medial and lateral femoral condyles, right? What are we talking about? These little guys here, right? So this kind of bony junk here, right? The medial and lateral femoral condyles. Knowing that that's a medial and lateral femoral condyle, what can we say in terms of image analysis about marker placement on this image? It's incorrect. This is not the left side. This is the left side. Okay? Good work. We want to see them symmetrical. We want to see that intercondylar eminence here, right? This little guy. Centered within the intercondylar fossa. Okay? So we've more or less centered right on the joint space, right? We're going to see a little bit of superimposition between that fibular head and the tibia, right? We can't really avoid that. But the main thing here is to make sure that that joint space is open. We'll see the patella just a little bit superior to the joint space. This is a little bit oblique, I agree. Yeah, this is marginally, and we can see that in part because of how that looks that way, and then you're right, there's a little bit too much superimposition right there. That's a good point. Ideally, we'd be able to see a little bit more minimal superimposition. And I think that's good. Soft tissue is critical on this image. All right. Here is something even a little bit more oblique. So is this image appropriately marked? Yes. Is it appropriately obliqued? That's right. This is a medial oblique. Yeah, so we have the leg turned in medially. Let's see, what else can we say about this? So again, the joint space is fairly well open. For the medial oblique, we want to see...
That is a lateral.
This is a lateral. Yeah, this is incorrect. Yeah, this is lateral. Sorry.
It says medial.
Yeah, for medial oblique, we want to see that head of the fibula free of any superimposition with the tibia. Okay? So what I'm talking about is we want to see this guy out here further to where it's free of superimposition out there. Okay? So this is a lateral oblique.
Do you think it might just be oblique enough?
I think it's still
I think
medial
it's
oblique.
medial
It's
oblique
just not
too.
oblique enough, because there's no way that's a lateral.
Lateral
Now
oblique.
look at the other way,
There
right?
were lateral obliques, because one was the left and one was the right.
Yeah, because it was wrong.
It's possible it's just not obliqued enough. But it's strange to me that the kneecap is where it's at. Like, yeah, I think you're right. I do think this is a medial oblique because we have the patella right here. It's just
Based on where your,
it's just not obliqued enough.
I mean, and also the joint space is more closed medially,
Right.
so that would make it.
Yeah.
would, and it, if it was lateral, wouldn't the fibula be more behind the tibia?
Yeah.
So I'm sorry. It is oblique. It's just oblique.
It's medial. The print on the bottom says it's medial, but I've learned that this textbook is not always accurate, so I'm just trying to unpack it some in my mind. Let me grab the bony guy.
I mean, but if it was lateral, wouldn't the fibula be more behind
Okay, you know.
I think it's a
Okay, that's
medial
how
oblique.
you say it. Right. You know well.
I think it's a medial oblique, but it hasn't been obliqued enough. And that's apparent because of the position of both the fibula and the patella. Okay, lateral. Is this a good lateral?
No, that is okay.
Yeah. What are some of the criteria that we're looking for to determine if we've got a good lateral in the X-ray?
You see a joint space between the patella and the femur.
Femoral condyles are
What do we call this joint here? Patellofemoral joint. We want to see superimposition of these structures. What do we call those? Yes, the femoral condyles. Good. Lateral and medial femoral condyles. We want to see those superimposed because if they're superimposed, we're going to see this joint space open more appropriately. Right? It is. This image is more or less centered appropriately. It may be a little bit low, but not much. I mean, centering wise, it may be a little bit high. But so that's the stuff we're looking for. We want to make sure that we have adequate contrast to visualize both bone and soft tissue, because sometimes we can see a little nick of bone or something like that with maybe some darkness around it. That would be evidence of an ACL tear. All right, that's one of the things that we can evaluate on a lateral knee X-ray. The patella is going to be situated proximal to the patellar surface of the femur, and we want that patellofemoral joint open. Then the distal articulating surfaces of the medial and lateral femoral condyles are superimposed. That's what we just indicated with those little half moon shapes, right? And the knee joint is more or less in the center of the exposure field. Okay. Here's an image of the intercondylar fossa. So this would be a posterior anterior axial, so a PA projection, like the Holmblad method, right? Where we have the patient's knee only slightly bent, and we have an angle on the central ray to open up that intercondylar fossa. Okay? This is an image, if you're interested in MRI at all, this is an image to become acquainted with, because this is one of the ways that we look for certain MRI images, right? Is having something that looks similar to this intercondylar fossa knee X-ray. So the medial and lateral surfaces of the intercondylar fossa are going to be seen in profile, right? And then we want to see those proximal surfaces of the intercondylar fossa superimposed. And then this knee joint open with the tibial plateau and the intercondylar eminence seen very nicely and cleanly. And then we want that intercondylar eminence more or less at the center of the exposure field and an appropriate marker in the appropriate place. Okay? Okay, patella. This is a tangential projection. We used to call this the sunrise projection or the merchant method. Basically what we're trying to visualize really clearly is if there's a patellar fracture. That's the number one reason that we would do this image. So like 4-view, 5-view knee. Some institutions have this included. Do they do these at any of the places y'all are at? Okay, good. Yeah, fairly common X-ray for the ER. The main thing here is we want to make sure that the patellofemoral joint spaces are open with no superimposition. And we are centered. If we're going to try to shoot them both, we're going to be centered right in the middle, right? If we're just trying to shoot one of them, we want to be centered more or less on that joint space. Yeah, it looks like this image is not appropriately flipped. Yeah, this thing here. Yeah, there's some kind of artifact. Good eye. All right, that's it. What are we talking about here? What are we looking at? AP knee, appropriately marked. It says it's erect. Why is that important to this image? Standing. So what might we be doing to, what might we be trying to evaluate on this image? Is it closing? So what might be causing this joint to close like this? Osteoarthritis. This is some serious bone-on-bone arthritis here. We can see it particularly on that medial aspect of the epicondyle. It's just all sorts of torn up. Okay? All right, so was everyone able to turn in a thingamajigger, technique chart thing? Okay. Okay. Get it to me soon. Next week, make sure you bring a draft of your outline. And I'll let you know if we're going to be meeting here or going directly to Mary. After Mary, we'll go to lunch, and then after lunch, we'll be coming back here so y'all can meet a candidate. I think it's 1:30. Oh.
She had it and it's changed.
It's changed a little bit, but I think it's still on. I'll let you know if that's changed. I assume y'all are ready to go.
Oh, sorry.
No, that's fine.
Well, you did say, well, we're done, y'all.
Oh, okay. I guess I did. Yeah, that's. We can say that's it. If anyone.
I mean, do you have more?
I do have more. I mean, look. That's it for the lecture. Can we stay for 30 minutes and do some knowledge bowl stuff? 30 minutes to do some knowledge bowl stuff. It'll be image eval stuff. Was that going to make you want to stay if it's final stuff?
No, I was just
No, this is really just knowledge bowl stuff. Okay. What teams do y'all want to work with?